Good morning, respected dignitaries. Our free paper is titled Post-Hoc Analysis of RCT on Injection versus Sponge-Based MMC Augmentation in Phacotrabeculectomy, and we have no financial disclosures. Glaucoma surgical trials today typically divide recruited participants into a number of groups, depending upon the type of interventions they receive. Thereafter, the apparent success or failure of the study intervention is determined by a time to event analysis, such as a Kaplan-Meier survival or Cox's proportional hazards. However, one must remember that this time to event analysis utilizes a life to death model, and several of censoring criteria such as IOP above or below a given cutoff cannot be akin to death because they may be altered post-operatively through additional interventions which are minor and anti-glaucoma medications. Herein lies the fallacy of results obtained through glaucoma surgical trials today, where participants are right censored permanently whenever this IOP threshold is breached, giving rise to a variable loss of information which might otherwise have given rise to slightly different outcomes. An alternative to this could be a multi-state model, but it is not commonly used in clinical practice because of the complexities involved. A midway path could be to identify an appropriate submodel from the complete model and perform an analysis on this, and this analysis would be equally easy and accurate. The aim of the study was exactly this, to apply this sort of a multi-state model approach on published RCT data to understand the true influence of different covariates on IOP control in MMC augmented phacotrabeculectomy. Methods. In the original study, there were two groups. One group received sponge-based MMC augmentation, and the other group received subconjunctival injections. There were 62 eligible participants in each arm. We performed a semi-parametric modeling on the published dataset. Our test covariates were age, gender, MMC augmentation type, and glaucoma medication intensity index calculated using Wong formula. A p-value less than 0.05 was used as the threshold to reject the null hypothesis. Results. For model simplification, in the first step, we eliminated the state repeat surgery because none of the participants underwent the same in the published dataset. We also realized that transitions from surgery to any other subsequent step on the first post-operative day was likely to be related to intraoperative factors, and therefore we eliminated that state as well. In the intervening model, we noted that the number of transitions between hypotony and target IOP were too low to perform a meaningful covariate-based modeling. Therefore, our final model was a bidirectional two-state model. A forest plot summary for crude and adjusted hazards for transition between IOP within target range to IOP above target range revealed that glaucoma medication intensity index was the sole predictor which increased the risk of this transition. In the reverse direction, in the adjusted model, sponge-based MMC augmentation and male gender reduced the risk of transition. Discussions. We found that the multi-state model reduced data exclusion from 39.19% in the alive death model to 6.72% and was more specific. Prolongation of anti-glaucoma medication use preoperatively increased the risk of high IOP postoperatively. This was probably related to chronic conjunctival inflammation and Schlemm's canal remodeling. Male gender and sponge-based MMC reduced the likelihood that IOP above target levels would recede to IOP within target zones. This was possibly related to increased risk of bleb encapsulation in males and hypofunctional blebs with sponge-based augmentation. What had been reported was that the route of MMC administration was the sole predictor which influenced phacotrab success. With this post-hoc analysis, we found that the multi-state model provided more information, and we noted that the preoperative anti-glaucoma medication was the sole predictor for loss of IOP control, while the mode of MMC augmentation merely influenced the ability of the filtration system to regain IOP control. The limitations of this post-hoc analysis was that statistical power could not be assessed, and there was asynchronous updating of the glaucoma medication intensity index, resulting in unmeasurable error in assessing the effect size. Thank you.
Can you, I know your analysis was extensive, but Can you tell that between the two, which had the bleb morphology was better in which, and the longevity of which bleb was better?
Madam, we did a post-hoc analysis. So in the published data set, we did not have any bleb morphology reported. So that is why I had put that question mark, because it is our assumption that the bleb morphology would have been poorer in the sponge-based group due to unfavorable pharmacokinetics.
Yeah, actually there are too many factors in a trabeculectomy to succeed or not to. So I think it is a very simplified version, but anyway, it's a good thought process. Thank you.
Thank you, sir.
Thank you, Dr.